Hello and welcome back. The topic of this video and the next few videos is quality assurance, or QA. So this is really a very important topic to ensure the quality of how we treat our patients. It's also part and parcel of the job of a medical physicist. So this is really an important topic. I'm going to approach this by breaking it up into 4 separate videos. So the first one, I'm going to talk about the principles behind the QA, why we do what we do. 2, I'm going to talk about QA of linear accelerators. 3, I'm going to talk about patient-specific QA, what you do right before a patient is treated. And then 4 is about QA of new technologies and systems that come online, like a treatment planning system or so on. All right, so we'll start topic number 1, principles of QA. One question you might have is, sort of in the broadest sense, what dose should we be trying to achieve? What is good? What is considered high quality? It's a difficult question to answer. You will sometimes see people point to this report, ICRU 24, published in the 1970s. In there, they actually state that we should be trying to achieve a dose that's within 5% of what's prescribed, because they point to some literature, some experiments, some clinical outcomes that justify this. This data from the 1970s, I don't know that it's been updated with more evidence behind that statement, but this is kind of a number to bear in mind as we go through this. All right, so let's get started. So I think it may help to start with this very general view of things. This is the Swiss cheese model of accidents, attributed to James Reasons. And the idea here is that you have some problem or deficiency or issue starting at the left, and it's potentially going to go and reach the patient on the right and cause harm. But you have these barriers or checks in place, and those are the slices of cheese, the Swiss cheese, that are lined up to try to stop this thing from going. So an example might be, say the problem was a wrong dose calculated in treatment planning. You might have one check that's a second double check by a physicist, or a hand calculation. You might have in vivo dosimetry, measurement on a patient, and so on. So there are all these checks in place, but unfortunately none of them is perfect. So that's what the holes are. So the holes are these deficiencies in the barriers. Yeah, so that's in the U.S., with apologies to my European friends, in the U.S. we have this thing we call Swiss cheese. It's cheese with holes in it. So if they line up, then it goes through to the patient. Depending on how that looks, you might have a barrier here that doesn't work quite as well as it should. And there you go. And it propagates through and potentially harms the patient. So that's the model. And in this video, we're going to essentially study these barriers, because these quality assurance measures and tests and checks, they're really nothing more than one of these barriers that's trying to prevent harm to the patient. So let's study and see how they work or don't work. So I think it's going to help to look at a specific example. So let's look at that. So we're going to look at LINAC output deviation. So the output, the number of centigrade per MU, let's say, deviates from what it should be, what you want it to be. So that's the problem. That's the example problem that we're going to study. In error prevention literature, this is called the failure or failure mode. That's what went wrong. And here's a cause. Let's say the gain is changed, let's say by an engineer in the ionization chamber in the LINAC. Here's another possible cause. Maybe there's a leak, a slow leak in the ion chamber, and that changes the pressure and hence the output measurement, and so the calibration is off. So those are some various ways that this could happen, this failure in output deviation. So these are causes, and there can be more than one cause, and they can interact. All right, and then the problem can manifest in different ways. So let's say the output deviation is large, let's say on the top here. Let's say it's 5% off from where it should be. So that's going to give you a dose deviation in the patient. So this is one example of how the magnitude of it. Let's do another one down here. Let's cut it in half. So let's say 2.5% deviation. And then we'll do another one a little bit smaller. So let's call this 1.5%. All right, so we're going to have to say how severe is that. So we're going to give it a severity score in terms of how it might hurt the patient. So let's give that an 8. These are on a scale of 0 to 10. That's a 5, and this I'm going to call a 2. It's somewhat subjective. We could kind of model it if we wanted to, but these are the scales. And then we're going to have to say how detectable is it. So there's going to be this detectability score, again from 0 to 10. And so I'm going to rate those here. I'm going to say that, well, first I have to explain the scale. So 10 means you can't find it, and 0 means you will find it for sure. So let's say for all of these, it's propagating through, and let's say I'm going to say we're not doing any QA. There's no QA measures in place. And so these I'm going to give that a 10. And this one I'm going to give a 10 too. And this one I'm going to give a 10 as well, because you're not going to be able to find this without QA. Okay, so then finally you get this risk score, overall risk, and that's the severity times the occurrence. Okay, I didn't talk about occurrence, but let's go back here to the cause area. So occurrence is how often such a thing would occur. I'm going to just, for now, let's give it a 10. It's just an example here. So we know it definitely happened. And then you multiply it by the detectability. So the maximum score is 1,000 that you could get here. Okay, so let's go through this example. So we'll multiply these together. So we got 8 times 10 times 10. So we get 800 there. That's the risk score. So it's a pretty high score. Let's do this one. So it's 5 times 10 times 10, 500. And then this one is 2, the severity of 2, occurrence 10, 10 is 200. Okay, so those are our risk profiles for these. And again, this is without QA in place in this clinic. All right, so to start to understand how this plays out with QA, then let's look at a specific QA protocol. This is Task Group 142, TG 142, from the AAPM, published in 2009, and it describes the kind of QA that you should be doing on a regular C-arm LINAC. Well, I'll come back to TG 142 in the subsequent videos, but for now I'm just using this as an example. All right, TG 142 has many checks and tests in it. One of them is an output check. There's recommendations around doing those. And here are one of those suggesting. So daily, you should be doing a check that's sensitive to variations that are at the level of about 3%, so that you could detect something that was 3% off. Monthly, checks should be done that can detect things at the 2% level. And then annually, checks should be done that can detect things at the 1% level. So coming back to our example then, let's see what that would look like if QA was performed as recommended in TG 142. So we'll start with the daily QA. Now remember the sensitivity of that test, so it can only find things that are 3% deviation. So it won't find this one, it won't find that one, but it will find this one. So this is just a function of how sensitive this test is, how it's performed. So let's add it in now to this branch here. So instead of having no QA, we're going to do daily QA as recommended by this report. And what that's going to do is impact this detectability score. So let's say it goes down to 1 now. You're almost sure to find it. And now we can multiply the risk score out again. Still 8 for severity, 10 for occurrence, but 1 for detectability. So now we get 80 for the total risk score. So you can see it went down a lot. This became much less of a risk for the patient because of this QA. Let's move on to monthly then. So that's 2% sensitivity. Again, you won't get this one, but you will get that one. You will get that one. Okay, so let's add it in, and we'll say, let's see how it affects this 2.5% deviation. We add in monthly QA as done according to this report, and the detectability of this becomes really good too. So it goes down to 1, let's say, and now we got 5 times 10 times 1, so 50. So it went down a lot by putting this QA in place, just as this one also went down a lot. The overall risk is much lower for these types of deviations. Okay, and then finally the last one, the annual QA, is added in here. See 1%, so that's detectable. But let's say you maybe there's some issue with the protocol, you don't always detect it. So let's give it a 2. and that goes down to 40, let's say. So you can see overall you're lowering the risk by putting these QA measures in. So let me just summarize that in looking at this in a slightly different way. So we have severe things, and then we also have very frequently occurring things, and it's one or the other or both, so medium, high, and low. And the QA, and so the QA needs are different. The QA needs will be driven by a combination of severity and occurrence or the risk. So basically more QA needed as you go up in either occurrence or severity. What does that mean, more QA? It could mean more frequent tests. That's the simplest version of that, and that's what we saw. So one thing you might be wondering as you look at the information from this example is about frequencies and sensitivities. You'll see we have a test here that's sensitive to output variations at the 1% level. So you might ask, why don't you just use that every day and be done with it? And it's a good question. And it has to do with how easy it is to perform those tests. And we'll see this in the coming videos. But basically, if you want to do a test that gets down to that 1% level, it's very cumbersome to do. It can take hours. And so to do something that's feasible on a daily basis, let's say, you're not going to be able to get down to that kind of sensitivity. And so it's a compromise between what's possible and what's necessary. And that's why these risk models are very useful. There's a formalism around this as described in AAPM Task Group 100, published in 2016, about risk analysis in radiotherapy. We'll come back to this and look at it in more detail in video 27. Now, before I leave this, let me make one more general comment on the scope of this. The example I showed was for physics QA of a machine, but QA applies much more generally. So if I zoom out, this shows a map of the entire clinical workflow process from A to Z. And QA can happen at many places along the way. For example, chart rounds, peer review of a plan, checks by therapists, checks by physicists, and so on. So QA can take many forms. And it's important to know that it's not just something that physics has to worry about, but is important to the clinic as a whole. All right, so with that, hopefully you understand some of the basic principles behind quality assurance. And in the next videos, we're going to get into the nitty-gritty, the specifics. How many millimeters do you have to be within specification for test number X and on a monthly basis, let's say. So it's going to get very granular very quickly. So hopefully it's good to take this first video and just understand the basics. I'm going to leave you with a reading list of further information, topics to dig into. And then in the next video, we're going to get into quality assurance of linear accelerators. All right, we'll see you.